globe, including over 20 here in the United States. And I think as we realize those numbers will be changing by the hour, they could be different by the end of this hearing, for all we know. This is not the first time, though, our country has had to deal with an outbreak, and it likely won't be the last. And we've been preparing for situations such as this. The Department of Health and Human Services conducted the Crimson Contagion 2019 functional exercise, a multi-state, whole-of-government exercise to assess the nation's ability to respond to a large-scale outbreak. Last summer, the President signed into law the Pandemic and All Hazards Preparedness Act, and since 2015, under Republican and Democratic leadership, for infectious disease response has increased by 70%. That's 70% in 5 years. While the virus is here now in the United States, we didn't see the first case until mid-January. Implementing travel restrictions bought us time, and mandatory quarantine helped to initially contain the spread of the virus. Unfortunately, community spread, positive cases for COVID-19 have now been reported in over 30 states. The New York State Department of Health is reporting over 140 positive cases. Again, that's as of this morning. At the rate they're going, I think there's already several more just in my county today. And a state of emergency was declared just this past weekend. Blind panic won't help us stop the virus from spreading. Cooperation, information sharing, and strong leadership is critical to successfully deal with a situation of this magnitude. We must ensure that proper protocols are put in place and the federal government works hand in hand with our state and local partners. As recommended, a national blueprint for biodefense by the Bipartisan Commission on Biodefense, I was pleased to hear last week's panel of witnesses agree with the President's election of the Vice President to lead the Coronavirus Task Force. To achieve a whole-of-government coordinated response to this outbreak, it is important that the person in charge has visibility to the entire government and a direct line to the President. The Vice President is the right choice. Now, while this has been a vigorous international, federal, state, and local response, as the situation continues to unfold, I encourage everyone to heed the advice of medical professionals, wash your hands, stay home when sick, and visit the Centers for Disease Control and Prevention's website for up-to-date information. I certainly commend the first responders, medical personnel, and public health officials who have responded courageously for those who were sick. Also, if I could just add, there are things we can criticize. I'm sure things could have been done earlier with this. And there's no problem with constructive criticism, but I think if we just criticize for the sake of criticizing, to me that really adds nothing to it. If we can do it in a constructive way, fine, and I'll say in a bipartisan way. In my state of New York, I think Governor Cuomo struck the proper balance, and also the county executives that I represent have done that also, saying that this is real, but we shouldn't panic, and trying to provide the best facilities possible. And I know that when this does hit a certain stage, they may be overrun, but I think that's what we should be striving for. And at the federal level, I would disagree with the ranking member on this as far as muzzling. I think it is important to get a coordinated response out. And again, there's valid criticism that can be made, but I think we try to keep it in focus and try to find ways to go forward. Otherwise, you have one side attacking the other, and then it goes back, and the American people get more confused than ever. So I'm not here to make I'm not here to explain away things, but I think it's important that we try to treat this as the serious issue that it is. And again, the more briefings we get, the more serious it is, and we should try to keep that focus in that way. So with that, Mr. Chairman, I yield back the balance of my time.
Thank you. And did you mean?
I meant Chairman.
Did you mean the ranking member or the chairman?
I was lost in the past, in the glorious past when I was chairman and you were ranking member.
Glory days. Yes. Okay.
I commend you as our chairman.
Thank you, sir.
I see Yvette laughing over there.
Other members of the subcommittee are reminded that under the committee rules, opening statements may be submitted for the record. I want to welcome a panel of witnesses today. Our first witness is Mr. Ron Klain, who is among many other positions in public service, was the White House Ebola response coordinator during the Obama administration, and provide lessons learned from his time battling a previous public health emergency. We also welcome today Mr. Christopher Neuwirth, the Assistant Commissioner of the Division of Public Health Infrastructure, Laboratories, and Emergency Preparedness for this New Jersey's Department of Health. In his role, Mr. Neuwirth provides strategic and operational leadership to coordinate New Jersey's hospital and public health disaster resilience laboratory services and emergency preparedness and response. Welcome. Next, we have Dr. Nadine Garcia, the Executive Vice President, Chief Operating Officer for Trust for America's Health, a nonprofit, nonpartisan organization that promotes optimal health for every person and community and advocates for an evidence-based public health system that is ready to meet the challenges of the 21st century. Welcome, ma'am. And at this time, I recognize the gentleman from Mississippi, Mr. Guest, to introduce our fourth witness.
Mr. Chairman, it is an honor for me today to introduce fellow Mississippian Dr. Thomas E. Dobbs III. Dr. Dobbs is the State Health Officer at the Mississippi Department of Health. Dr. Dobbs has served in this role since 2018. Dr. Dobbs has also held previous positions as the Health State Officer and the State Epidemiologist. He is board certified in internal medicine and infectious disease and practiced in Mississippi before joining the Department of Health. Dr. Dobbs holds a doctorate of medicine and a master's in public health from the University of Alabama at Birmingham. Dr. Dobbs, I personally want to thank you for providing your expertise on this panel today as an infectious disease physician and for sharing about the coronavirus preparation you are leading in Mississippi. I'm proud you have joined us today for this hearing and look forward to hearing your remarks. Thank you, Mr. Chairman, and I yield back.
I thank the gentleman. Without objection, the witness's full statements will be inserted into the record. I now ask each witness to summarize his or her statement for 5 minutes, and we are going to restrict time today, beginning with Mr. Klain.
Thank you, Mr. Chairman. Ranking Member King, thank you for having me here today. Before I begin, I'd like to make two preliminary points. First, as frustrating as it may be, there's still a great deal we do not know about the coronavirus and the disease it causes. In fact, we know less about the coronavirus today than we did about Ebola in 2014. Scientists are working at breakneck speed to improve our understanding, but as we learn more, our response to the virus will have to change. Secondly, while I am a political partisan, I come here today in the same way that I approached my tenure as White House Ebola Response Coordinator, putting politics aside. There is no Democratic or Republican approach to fighting infectious disease, only sound and unsound measures. It doesn't mean demurring, calling out failures where they appear. I have been critical of many aspects of the administration's response to the coronavirus. Likewise, I've praised other steps that the administration has taken. Putting politics aside does not mean putting judgment aside. With those two preliminary points made, I want to move on to how we can use the lessons we learned in the Ebola response to approach the current threat. To be clear, the Ebola response itself was not without problems and mistakes, but ultimately President Obama mustered an all-of-government response to the challenge, authorized the first ever deployment of U.S. troops to combat an epidemic, and appointed me to lead a team of talented and dedicated professionals at the White House to coordinate the effort. In the end, that epidemic was tragic. 11,000 people more died in West Africa. But in September of 2014, there was a forecast that 1 million lives would be lost. America's actions as part of a global response saved hundreds of thousands of lives. The ongoing legacy of this work is enormous. With Congress's support, we implemented a national 4-tier network of hospitals and medical facilities that remain prepared to this day to identify, isolate, and treat cases of dangerous infectious diseases. Nothing like that existed in 2014 before we started. Work on vaccines and therapeutics as well. Now, the challenge we face from the coronavirus epidemic is different in many ways, but it contains some similarities. And so I think it's worth thinking about the lessons that can be applied in this case. First, in a complex, rapidly evolving scenario like we're seeing, there's no substitute for White House coordination and leadership. At the end of my tenure as Ebola Response Coordinator, President Obama accepted my recommendation to create a permanent pandemic preparedness and response operation inside the National Security Council that continued through the first year of the Trump administration, but in July of 2018, that unit was disbanded. The administration's decision now to go through a series of different structures for First, no task force, then a task force led by Secretary Azar, then a task force led by Vice President Pence, then Ambassador coordinating the response, has produced uneven results and certainly has contributed to the largest fiasco in the U.S. response, the failure to promptly enable widespread testing for the virus, which definitely is a result of some lack of coordination between CDC and FDA. There is simply no reason, none, why the United States is behind nations like South Korea and Singapore in protecting its people. Second, we must ensure that science and expertise guide our actions, not fear, wishful thinking, or politics. There are reports, as Chairman Payne indicated, of senior officials in the government rejecting the advice of professionals at the Centers for Disease Control and other aspects of sidelining or ignoring medical advice. There are many policy decisions to be made in the days and weeks ahead. Science and medical expertise must guide them, not politics. Third, the U.S. has to lean forward in fighting this epidemic overseas, as that, I think, will become an increasing priority. Unlike what happened in West Africa in 2014, the nations of China or Italy, where it's South Korea, do not need our help in responding. But this disease could easily spread to Africa and to other countries where we might have to step up and do the same kind of things we did in 2014. Fourth, the administration must move quickly to implement the emergency funding bill passed by Congress last week. Congress deserves great credit for acting with unprecedented speed in funding this response. But passing a funding bill is only the first step, not the last step. Congress needs to make sure that the administration is getting that money out and getting it out quickly and effectively. Too often bills get passed and they don't get implemented. That has to be a priority. The White House task force should report regularly to the American people on the pace and deployment of the funding Congress provided. Where is the money? When is it getting out? What's going to be done? Fifth, Congress has to continue to do its own work on the coronavirus. That includes hearings like this and ultimately work on things like the economic consequences of the virus. Sixth, both the executive and the congressional branch need to work on the long-standing issues of pandemic preparedness that remain. It is not clear if it will be the big epidemic that we've seen coming, like the Spanish flu was 100 years ago, but sooner or later it will come. There is a raft of partisan proposals sitting on shelves that Congress has never acted on. Let this be a reminder of the need to act on that. And then finally, I just want to close by saying public officials at all levels of government need to take steps against discrimination. We're already seeing discrimination against Chinese Americans, Chinese American-owned businesses that will spread as this virus spreads. This virus affects humans, not members of any race or ethnicity. We need to step up and make sure there are no victims of that discrimination. Thank you, Mr. Chairman.
Thank you. The chair now recognizes Mr. Neuwirth to summarize his statement for 5 minutes.
Good afternoon, Chairman Payne, Ranking Member King, and members of the subcommittee. On behalf of New Jersey Governor Phil Murphy and New Jersey Health Commissioner Judith Persichilli, thank you for inviting the New Jersey Department of Health to participate in today's hearing. I'm here before you as the Assistant Commissioner for the Division of Public Health Infrastructure, Laboratories, and Emergency Preparedness. I'm responsible for public health emergency management services, and the public health and environmental laboratories. My goal today is to share with you New Jersey's experience for preparing for and responding to the novel coronavirus public health crisis. More so, I will share with you experience working with our federal partners at the U.S. Department of Health and Human Services and the Centers for Disease Control and Prevention. I am hopeful that by sharing with you how New Jersey has responded to the novel coronavirus public health crisis, that you will be able to strengthen and enhance the coordination between critical federal agencies and all states, including New Jersey. Throughout January, the Department of Health actively monitored the public health situation arising from Wuhan City, China. Our public health experts and epidemiologists readily identified a concerning novel pathogen that undoubtedly had the potential to escalate into a global pandemic. Under the leadership of Commissioner Persichilli, on January 27th, I established an internal crisis management team using National Incident Management System principles to coordinate preparedness and response activities from across the department. Shortly thereafter, on February 3rd, Governor Murphy signed Executive Order 102, creating a statewide coronavirus task force led by the Commissioner of Health. Since their creation, the Crisis Management Team and Coronavirus Task Force have provided the state of New Jersey with an independent command structure that has allowed all departments to effectively organize, coordinate, and prioritize their preparedness and response activities. Simply stated, New Jersey continues to successfully manage the public health crisis because of our strategic organization, subject matter expertise, and our collective institutional knowledge. While I certainly could continue describing all of the great work New Jersey is actively doing, I must draw your attention to the two most important aspects of any nationwide public health response: coordination and communication. On Sunday, February 2nd, during the afternoon of Super Bowl Sunday, the New Jersey Department of Health was notified that Newark Liberty International Airport would officially be designated as the 11th funneling airport in the United States, with the first arriving flights arriving within 24 hours with more than 350 travelers on board from China. Within moments of receiving this news, our crisis management team began working feverishly to secure housing, transportation, and rapid services for these individuals potentially facing quarantine. Because we had established a crisis management team that was well organized, highly disciplined, and remarkably proactive, we were able to effectively coordinate a measured response at a moment's notice. More importantly, as New Jersey begins facing its cases of novel coronavirus just last week, the crisis management team and coronavirus task force continue to effectively coordinate all aspects of the state's response to ensure that communications remain organized, timely, and in the public's best interest. Throughout the past 8 weeks, my team has been in lockstep with our friends and colleagues at the U.S. Department of Health and Human Services and at the CDC, at headquarters and within Region 2. The daily interactions and near real-time communications during fast-moving situations has allowed the state of New Jersey to effectively communicate and coordinate our activities between all stakeholders. As novel coronavirus continues to affect New Jersey, the strong relationships we have with federal counterparts ensures that we can communicate candidly and resolve issues immediately as they arise. In a dynamic public health crisis such as this, maintaining tight coordination through streamlined, clear communications greatly increases the effectiveness of our collective response. But in our great partnership with our federal colleagues, the state of New Jersey expends more than $1.8 million per month responding to novel coronavirus. While our CDC award of $1.5 million is greatly appreciated, it certainly will not cover the continued expenses incurred by the state or the healthcare and public health infrastructure, including our acute care facilities, EMS agencies, and local health departments. Recognizing that medical supplies are facing a historic shortage and that healthcare supply chain is nearly frozen for respirators, disinfectants, and other personal protective equipment, we urge you to consider additional funding to New Jersey and the distribution of items from the Strategic National Stockpile. New Jersey remains committed to fighting novel coronavirus and protecting the public health and safety of all people living in and traveling through New Jersey. As the country continues to respond to this public health crisis, we ask that you remain attentive to the evolving needs of each state, specifically New Jersey, and mobilize the information, resources, and funding needed to protect the nation's public health and safety. Thank you.
Thank you, sir. And our next witness, I was told by my staff that I butchered your name, so I will try to better. Ms. Gracia. I'm sorry about that. I now recognize you to summarize your statement for minutes.
Thank you, Chairman Payne, Ranking Member King, and all the members of the subcommittee. Good afternoon. My name is Dr. Nadine Gracia, and I'm the Executive Vice President and Chief Operating Officer at Trust for America, also known as TIFA. TIFA is a nonprofit, nonpartisan public health organization which, among our priorities, has focused attention on the important, strong, and effective public health emergency preparedness system. Over the past nearly 2 decades, TIFA has published an annual report called Ready or Not, Protecting the Public's Health from Diseases, Disasters, and Bioterrorism. In our most recent report, we identified areas of strength in our emergency preparedness, as well as areas that need attention at the federal and state levels. Discussion of our report findings, including our state assessments, can be found in my written testimony or on our website. I would like to highlight some of TIFA's policy recommendations to build our nation's preparedness for our public health emergency and improve the national response to the novel coronavirus disease, or COVID-19. First, we applaud Congress for rapidly approving a robust emergency federal funding package. Federal agencies should be preparing now to quickly distribute funds to other partners. Second, Congress must prioritize ongoing investment in public health and annual appropriations. The nation's ability to respond to COVID-19 is rooted in our level of public health investment in the last decade. The nation has been caught in a cycle of attention when an outbreak or emergency occurs, followed by complacency and disinvestment in public health preparedness, infrastructure, and workforce. The Public Health Emergency Preparedness line, which supports frontline state and local public health preparedness, has been cut by over 20% since fiscal year 2010, adjusting for inflation and on top of steady cuts since 2004. In addition, we have long neglected our public health infrastructure, so many health departments are relying on 20th century methods of tracking diseases such as via paper, fax, and telephone. Congress should prioritize funding for data modernization and help with emergencies as well as ongoing disease tracking. Third, we need to ready the healthcare system for outbreaks. Health systems across the nation are beginning to identify, isolate, and care for patients with COVID-19. Healthcare must prioritize the protection of patients and healthcare workers, including appropriate training on infection control practices, personal protective equipment, and surge capacity. Unfortunately, funding for the hospital preparedness program helps prepare the healthcare system to respond to and recover from emergencies has been cut nearly in half since 2003. Fourth, Congress should support the medical countermeasures enterprise, including BARDA and the Strategic National Stockpile, which build the pipeline of vaccines, medical equipment, and supplies for health security threats. Fifth, we must build the pipeline of the public health workforce. Although supplemental funding may help with short-term hiring, this temporary funding does not allow for recruitment and retention of workers. Emergency preparedness and response are personnel-intensive endeavors that require training, exercise, and coordination across sectors. This experience just cannot be built overnight. Sixth, Congress and employers should consider job-protected paid sick leave to protect workers and customers from infectious disease outbreaks. One of the recommendations we have repeatedly heard is to stay home when sick. For millions of Americans, that is not a realistic option. They risk losing a paycheck and possibly their jobs if they stay home when sick or to care for a loved one. In fact, only 55% of the workforce has access to paid time off. Congress should pass a federal law to require employers to offer paid sick days as soon as possible. Finally, science needs to govern the nation's COVID-19 response, led by federal public health experts who have years of experience in responding to infectious disease outbreaks. Keeping the public and partners informed will be critical. We encourage elected officials and community leaders at all levels to make policy and communications decisions based on the best available science, understanding that the situation is evolving rapidly and messages may change. Communities considering school or business closures should follow public health guidance, but also consider unintended consequences. For example, nearly 100,000 schools serve free and reduced meals to 29.6 students each day. The U.S. Department of Agriculture should be implementing flexibility for schools to make grab-and-go meals and other options available when schools are to close. The full extent of this outbreak in terms of public health, healthcare, and economic and societal costs remains to be seen. We do know that taking immediate steps to mitigate the effects of this outbreak will save lives and prevent harm. Thank you for the invitation to participate today, and I look forward to your questions.
Thank you. I now recognize Dr. Dobbs to summarize his statement for 5 minutes.
Chairman Payne, Ranking Member King, distinguished members of the committee, thank you all so much for having me. Let me get a little closer. Yeah, is that better? All right, great, thanks. Hey, thank you all for having me. I really look forward to the opportunity to talk a little bit about why public health is important. Why is it different from healthcare? Why is it really relevant to what we're talking about right now? When I was in medical school back in the 90s, I thought I was going to be a medical scientist. And I spent in my initial part of my career and much of what I was doing, I was working on HIV control and tuberculosis control, not only in the American South, but also in Southeast Asia and in Russia. And learned a lot, not only about medical things, but the value of public health. If you want to have an impact on a community, you can't look simply at the individual. You have to look at the community and the environment that surrounds that person. And it's this public health investment that allows us to do the work we need to do to make sure that the public, the community, and the individual is maximally protected. Now, switching a little bit to the coronavirus conversation. So A virus is a virus, and although most people will get over it without a lot of sequela, it will be very impactful, especially for older folks. As we've seen, the mortality rate among older people infected has been really bad. And we need to make sure that we tailor our responses to those that are going to be most affected. We have tools in place now that public health has been using for years to look at different things. And in Mississippi, for instance, we have these massive, significant flu outbreaks in nursing homes every year. And we've learned very quickly, if we implement those basic public health responses like rapid identification, immediate isolation, quarantine, restricting visitation, that we can actually severely limit the impact on our folks. The things that we've learned year after year from not only our sort of micro outbreak responses, but also too from these major things, H1N1, we're talking about Ebola, Zika, chikungunya. We build up expertise. We build up capacity. We build up tools. When we talk about Ebola, we scrambled, right, because it was a new thing, and what do you do? And the community is really scared about what's going to happen with people in the community. So we basically gather technology to do home monitoring using mobile devices. But building on that foundation, we were then able to go on to use this for our folks coming over for coronavirus. These historical lessons help us work to the future. But one of the challenges that we face is this bolus of funding up and down, where sometimes we will get specific money to address a specific issue like Zika or like Ebola, but then as that crisis resolves or sort of changes, then we have to contract back to a state of acceptable but not sufficient readiness. When we look at what's going on in Mississippi right now, we have activated our agency emergency response functions, and we are working closely with our state emergency management agencies. Within Mississippi and other states, we have a pandemic response plan that's tailored around influenza, but we know that the elements within that plan are well suited to the response for pandemic virus. And pulling together different experts within our state, especially under the Governor Reeves passed a executive order, put a new planning committee, we're going to leverage that information that we got from responding to H1N1, making sure we're prepared for that next flu pandemic forward. But we can't really make sure that we advance those efforts unless we have some steady funding and don't go through this perpetual roller coaster cycle of funding for one thing that's limited to that, don't have the flexibility then to use it for the next thing. I really think that we could almost use less money given more stably over time and be more effective if we were able to be prepared for the next thing. Also, let's talk about innovation. I think innovation is very important, making sure that we not only in technology for surveillance, because the things that we use for public health are high-tech, data-rich environments. We just recently in Mississippi in artificial intelligence business analytics, trying to look at what's going on with outbreaks in our state. These are things that are not inexpensive, but it's not only the software, it's also people that you have to do that. If you want to have the best people doing the most important job, we need to make sure that we build up our public health workforce and have the people there that can do what they need. And then telehealth, I would like to really say I appreciate the creativity expanding telehealth options as we're looking at this COVID response, because what's going to be better than making sure people can be taken care of their home, either if they're unable to get out or if they're being monitored, but also too these older folks who might need to be coming in for other non-medical reasons besides a viral illness, they can stay home and be cared for and not come into the healthcare environment where they're going to be exposed to these potentially dangerous things. And we're proud in Mississippi to have a telehealth center of excellence where we are advancing telehealth capabilities to reach people in all sorts of areas, and the Department of Health has with them. And I would like to thank you for the funding coming down. We will put it to good use and make sure we do our best to cut off this epidemic. Thank you.
Thank you. I'll now recognize myself for 5 minutes of questioning. Thank you. This question would be to panelists. Many have criticized the administration's outbreak response for being too slow to realize the severity of the threat. How would you assess the U.S. government's response, and what aspects of the government's response could could be improved upon? Mr. Klain?
You know, Mr. Chairman, I say there's two things where we're lagging. The first is this testing issue. Again, as I said in my statement, there's no reason why other countries, South Korea, are so far ahead of us. 100,000 plus tests in South Korea, less than 5,000 in the United States. And I think that's a product of some bad decisions made at the CDC and a lack of a real effort to accelerate testing around the country. The second thing I think is hospital preparedness. In various communities, our hospitals are going to see an influx of cases, and I don't think we've been prepared for dealing with that, whether that's working with FEMA to temporarily ramp up capacity in those hospitals, or to do things like they're doing in Korea and Germany with drive-through testing, other things. We need to be creative and flexible about really increasing the capacity of our system to deal with the influx of cases we're going to see.
Thank you. Mr. Neuwirth?
I agree with Mr. Klain in that the testing capabilities of each state are something that needs to be addressed here in New Jersey. We've only received 2 test kits to date. I'm recognizing that our 9 residents are actively dealing with SARS-CoV-2, novel coronavirus. We would expect additional capacity in the state of New Jersey to effectively and efficiently test everybody that needs to be tested. And to date, those 2 test kits, are something that needs to be. The second is that recognizing how fast-moving the situation was, even back in January, it's important that information be shared in a timely manner as effectively as possible and ensure that decisions made at the federal level are effectively communicated to the states to ensure that the states are in a position and maintaining a posture to implement the policy decisions made at the federal level. The greater lead time that the states are given, the more effective and appropriate those implementations are.
Thank you. Ms. Gracia?
Yes, I would emphasize the importance of the coordination and really coordination of agencies and having senior level coordination as we are seeing now through the White House with the coronavirus task force. Secondly, the importance of continuing to rely on the science and the evidence to make decisions, whether it's policy decisions, public health guidance that is being out by the federal agencies, that we continue to rely upon the expertise and the experience of the scientists as well as the medical and public health experts.
So we need to believe and trust the science that is coming along. Thank you. Dr. Dobbs?
Thank you. It's a very complicated and rapidly evolving situation. I understand it's very challenging. By and large, CDC has been very responsive to our needs. I can call the ship pretty quickly. We at Mississippi, we're a little bit behind in the sense that we don't have much in the way of testing, but we do have adequate testing capabilities at this time. I would say that early on, if we were given some more flexibility in who we test, I think that would have been good. There were pretty strict guidelines at the beginning. The other thing is preparedness to begin with. I think the CDC coordination with Border Patrol was a little bit difficult at the very first when we were getting our travelers in. A little bit of hiccups with that. But they've been very responsive, and it's a difficult situation, and I just really do appreciate the work of CDC and the assistance that they give us.
Thank you. In the interest of time, the chair will recognize the gentleman from the ranking member, Mr. King.
Thank you, Mr. Chairman. Let me just, ask Mr. Neuwirth and Dr. Dobbs. Again, you sort of touched on this already, but what improvements could be made in coordination with the federal government now? I mean, allowing for whatever's gone wrong in the past, but as of today forward, or as of the last several days going forward, how do you see the level of coordination and what improvements can be made?
I think the coordination even among federal agencies would be because we have seen some miscommunications between those levels, which then kind of trickles down to us that can be a little bit difficult. Quick communications are very important, and by and large, I think that's been very good. I think clear understanding of what funding is going to be available and what we can use it for. And also, I can't say how much I support the hospital program. I think that's been cut some over the years. That's really a foundational element for these sorts of responses. We have pulled back from, I think, actually cashing up as many supplies and PPE as we had in years because that has the priority on that has shifted a little bit. I think that would be very important.
Mr. Neuwirth.
Specifically reference Joint Base McGuire, Dix Lakehurst. This is a base used by our federal partners as a potential housing solution for quarantined individuals. New Jersey has put forth a remarkable important resources to ensuring that this housing solution remains intact and fully functional to meet the demands of the situation. And the base was operational for an initial 2-week period, and the state, up until the absolute deadline of Friday at 8 a.m., was unaware whether or not that the base would remain operational for the quarantine, as a quarantined housing solution. So ensuring that New Jersey can appropriately support this housing solution moving forward. This is one example of where understanding where the federal government sits as far as continuing this operation and how we can best support it is important to us.
Mr. Newworth, since New York and New Jersey are so close, I have a very parochial interest in this. We have probably tens of thousands, if not more, commuters back and forth every day. What's the level of coordination between the states? And also, I know Governor Cuomo has gotten approval for New York to do its own testing. Has New Jersey applied for that approval?
Yes, so we are doing our own testing in the state. Right now, as of today, the state's public health environmental laboratories is the one in New Jersey performing the tests in state and ensuring a rapid turnaround time as best we can. We are in lockstep with our New York City and New York State partners. We have, historically, we've had a phenomenal relationship with the city and the state just because of our close proximity, the way we manage and deal with risk together, how we conduct our preparedness and response activities are often in lockstep. And so it's historical relationships that we've been able to leverage for this event that has ensured the relationship's been maintained and leveraged so that both sides of the river are fully aware of what the other side's doing so that we remain in lockstep.
Mr. Klain, first of all, let me thank you for your efforts in Ebola. It was outstanding. I give you full credit for that. And Governor Cuomo announced something today. I just wonder if this was ever contemplated if the Ebola virus had not been contained the way it was. He has actually ordered the National Guard into County. New Rochelle is going to be a 1-mile containment zone. Basically, it originates from a synagogue, and that's, I think now there must be 50 to 100 cases, if not actually diagnosed, but certainly people are being tested from that area. Was that ever something that was contemplated by you? I know it's really, I support the government doing it, but I can see if it's carried to a larger level, it's going to shut down almost any community center, house of worship, school. It'll leave certain businesses open, but did you contemplate how that would actually be implemented?
Congressman, we did not. We never expected to have that many cases of Ebola in the United States. We were focused on isolating people when they came here from West Africa and getting them promptly into treatment. I do think, though, that this subcommittee should look at the issue raised by this, kind of quasi-quarantine of New Rochelle and what other measures could be effective. And I also think thinking about the National Guard or FEMA to help increase hospital capacity, tent hospitals or rapid treatment centers, I think, we're going to need person power to help respond. And at a time when our healthcare system, see doctors and nurses drop out because they're sick, they're going to get the virus too. So I think, thinking creatively about who can really help power this response is an important thing.
Also, as far as thinking, I'm sorry, my time is, I go back. Thank you. Thank you very much.
Thank you. The chair now recognizes the gentlelady from New York, Ms. Clark.
Thank you very much, Mr. Chairman. I thank our ranking member and our expert panelists for coming in to share your expertise with us today. We know that America needs a fully funded, whole-of-government response to stay safe against the coronavirus. In my home state and city of New York, we are in the midst of an unprecedented health crisis. Leaders should not minimize or exaggerate the scale of the task before us. We can beat the coronavirus. The administration needs to set politics aside and put scientists in the driver's seat. Having said that, Mr. Klain, after weeks of stating that enough resources were available to fight the coronavirus, the Trump administration finally announced that it was seeking an emergency supplemental with additional resources available. This request was made more than a month after the first recorded case of coronavirus was discovered in the United States. How would a timelier request, have helped the U.S. respond better?
Congressman, I think that's a good question. I testified before the Foreign Affairs Subcommittee about a month ago and said that the request should already be here and Congress should be acting on it. I do think that more funding might have accelerated this testing situation, might be helping states more quickly. And I think it's important to know, again, Congress deserves great credit for passing this funding quickly. The question is, how quickly does it go from Washington out to the states? The gentlemen and ladies to my left here, they're going to have to actually make this work on their own, and they can't unless the money moves from Washington to them. And I think that's really where we should be focused on now, is once Congress did this incredible thing of 2 weeks writing and passing a bill, is the money really getting out there to ramp up testing, to ramp up healthcare systems, to help the people who are going to need the help?
Very well. This question for both you and Dr. Gracia. I think many of us in Congress were shocked and disappointed that the administration's initial proposed amount for the emergency supplemental was only $2.5 billion. Luckily, Congress passed an $8.3 billion supplemental that was significantly more robust than the administration's request. What more can the government do to ensure that there's enough funding to support state and local outbreak response efforts? And I'd add to that, leaving an infrastructure in place so that we're not rebuilding the infrastructure time and time again as these outbreaks occur, because certainly there will be others.
Congressman, I agree with that so strongly. I kind of agree with what Dr. Dobbs said earlier. The issue sometimes is the amount of money, and the other issue is the consistency of the funding. We today are in the middle of an epidemic, and that's what we're focused on, as we should be. 3 years away from the next one, and 3 years from the one after that, and 3 years from the one after that. And it's these boom and bust cycles in funding that really undermine our preparedness. And I hope that what Congress will take out of this is great job on the emergency supplemental, but what are we doing to prepare for the big threat that is out there in the future?
Thank you, Congressman. You raise a very important point and question, and one is a recognition that I think you certainly have, that public health departments at the state and local level, they're truly our first line of defense as it relates to these types of outbreaks, to other natural disasters where there are public health consequences. And what we have seen, however, is that there really has been a longer-term underfunding of public health, and that there have been cuts that have really impacted public health departments at the state, local, tribal, territorial levels. We look at, for example, the Public Health Emergency Preparedness Grant that's administered by the CDC, that has experienced cuts over the years, 20%, more than 20% over the past decade, or the Hospital Preparedness Program, which has been cut in half since 2003. These are important funds to really be able to support public health over time, to be able to continue to have the type of emergency preparedness response infrastructure for surveillance, for the workforce. It's very difficult to hire individuals for the short term and be able to guarantee that they're going to be able to stay on board and really build that training and capacity within the public health departments. And there also is a need for more funding as it relates to the core capabilities in public health, things like pandemic preparedness, but also communication expertise, epidemiology and surveillance expertise, the ability to bring together coalitions. These types of areas are truly fundamental for core public
health. The Trump administration has repeatedly attempted to cut funding to public health. Could you describe how chronic underfunding of public health makes the United States more vulnerable to outbreaks? Yes, I'm sorry. Ms. Gracia.
Certainly. So I think one is to recognize that we have made actually important progress, in particular over the past 2 decades as we look at public health's level of preparedness, in particular since the September 11th attack. That there was a recognition that public health really is part of the national health security enterprise, and that we needed to really bolster that infrastructure, which is inclusive of laboratory capacity, the workforce, being able to have the surveillance systems in place and communication systems in place, as well as looking at coalitions built between public health and health care. But as I noted earlier, what we need to do is really build on the expertise from these previous outbreaks and other types of public health threats. These are the individuals who have been through these types of outbreaks and other public health emergencies in the past, and recognizing that the need to have stability in that funding so that not at risk. We have seen, for example, over the past decade, the budget to the Centers for Disease Control and Prevention has declined by 10%, and a large percentage of CDC's goes to state and local health departments.
Thank you, Mr. Chairman. Yield back.
Thank you. I recognize the gentleman from Mississippi, Mr. Guest.
Thank you, Mr. Chairman. Dr. Dobbs, you and I had a chance to visit earlier before your testimony, and you and I discussed about the fact that we currently in Mississippi have both the ability and the capacity to test for COVID-19 in our home state. Can you talk just a little bit about that?
Part of it may be that the timing was advantageous, but we were able to bring up the testing pretty quickly. Our public health lab, within a week of getting the reagents and the guidance, was able to get the testing activated. So far, we haven't done a ton of testing, about 50, but they're all negative. We've got many coming in every day. We think we have sufficient capacity to meet demand for the near future, but also fortunately now with private lab capacity coming online, like LabCorp and others, that will help with the clinical environment. And I'm looking forward to the opportunity where public health can fulfill a different role, which is mostly going to be surveillance, so that we can have a better understanding of what's going on in different communities. And also maybe acute testing, we can run it in about 4 hours after we get a specimen. So if there's something that needs to happen right away, we can execute that.
And can you talk a little bit about your response that you've received so far from CDC?
In response to the testing, it's been good. The information that they've been giving us has been very helpful. Their guidance has been very good, especially their guidance documents for clinical scenarios. I will say their website's kind of cumbersome. I need to talk to them about that. It doesn't come as fast as you'd want it, honestly. I mean, we're always sitting on go for the next thing, but the quality of the work has been from our perspective.
And Dr. Dobbs, you talked in your opening statement and some of your questioning, and then in your written statement about the use of telehealth. And you say here that telehealth will greatly assist in community mitigation efforts by improving efficiencies, permitting ill patients to stay home, and allowing non-COVID-19 patients access to health care without coming into physical contact with a clinical environment. Could you explain that very briefly again?
You bet. If you think about who's at risk for bad outcomes from COVID-19, it's going to be older folks primarily, people with chronic medical conditions. And these are people that are going to access the healthcare system quite frequently, and a lot of it's going to be non-urgent, things that can be done telehealth platform. And so we've really been pushing hard with our partners at UMC, and actually I was talking with some of the other big health systems today, meeting with Blue Cross, trying to help them set up systems where they'll fund communications with people from their home, so that you don't have to right now, or at least previously, you have to go to another clinic setting around a bunch of people. It's so much more convenient. This is not only an opportunity for us to help with COVID-19, but maybe even sort of catapult the future of healthcare by thinking about what telehealth could look like.
And is it conceivable that telehealth could be used to help screen individuals as they are coming into the country ports of entry?
In a place like Mississippi, especially where we don't have a lot of medical providers and we have a pretty rural geography, if we could leverage telehealth for function or any other function that requires medical intervention, it really does expand our reach remarkably.
And Dr. Dobbs, you talked about the importance of the hospital preparedness program. Could you expand on that just a little bit?
If we think about who the boots on the ground, who are the people who are going to respond locally when something goes awry? It's going to be those local community folks. It's going to be the local emergency management folks. It's going to be the hospital. It's going to be the clinic. It's going to be the people who are in that area. And the Hospital Preparedness Fund lets us organize these healthcare coalitions. We can have a reach into the communities and respond, but also make sure that hospitals are ready, not only in supplies, but also planning, because they're going to be at the And the thing that worries me more about this than anything is going to be resource utilization within our hospitals and intensive care units. Even now, if we have a bad flu year, we run out of intensive care units. So having that core infrastructure to make sure that we're ready when something above and beyond happens is going to be very important.
And so that helps you in your logistics as you are trying to find placement for individuals who are ill, whether it be with coronavirus or some other illness that they'd be battling.
Absolutely. And then also, even within the HPP program, there are some flexibilities that might help. Like, for instance, we have a warehouse of PPE that we keep. We have about 200,000 masks that we can distribute immediately if we need to, so we're ready to go. But based on some of the structure of the HPP program, we only can use 10% of it for overhead but they count rent for the warehouse as overhead administration. So we would welcome flexibility and funding for HPP as well.
And Dr. Dobbs, very briefly, just for the people back in Mississippi, can you talk a little bit about the emergency supplemental funding and what that will be used and how that will be used to fight coronavirus back home?
Yes, we have got a laundry list of things we want to do. We want to expand surveillance. We want to increase lab capacity. We want to expand on our informatics. We've already started doing some advanced analytics using biosense to figure out where cases are going to be. We want to make sure that we have resource allocated for PE or other things to support hospitals. I've already brought on 3 doctors. I don't know how I'm going to pay for them, but I guess this is how. And then and nurses, boots on the ground to get the work done, and then advancing technology and equipment and other PPE needs.
Thank you, Dr. Dobbs. Mr. Chairman, I yield back.
Thank you. The chair now recognizes the woman from Illinois, Ms. Underwood.
Thank you, Mr. Chairman, and thank you to all of our witnesses for being here today. It's a pleasure to see my former colleagues from the Obama administration here today as we chart a path for Congress to lead the response to the coronavirus. Mr. Klain, what essential leadership functions must our federal government when it comes to helping the public, state, and local public health departments, employers, and our healthcare system navigate this public health crisis?
Congresswoman, I think it's a question of both competence and confidence. So I think on the competence side, the government has to provide the leadership and the funding to deliver this response. This is going to be a giant project to manage these cases, to roll out testing, as the panel has discussed, to help our healthcare system get prepared for the influx of cases, and to deal with all the other things, the contact tracing the state and local public health departments are going to do as we move towards containment, and all these other things. And so the federal government has to provide expertise in the form of the CDC and people at ASPR and BARDA and other agencies. It has to provide funding. It has to provide leadership. But it also has to provide confidence. I think we need to see from Washington clear direction and messaging so the American people can panic less and can understand that there is a plan in place and a way of attacking it and so on and so forth. And I think those things, we just have not hit the mark on that yet, and we need to do better on both those fronts.
Thank you. Dr. Gracia, you recently published a report evaluating states' ability to respond to emergencies like the coronavirus. What did you learn from publishing that report about the actions the federal government must be taking to support state and local public health departments in addition to providing supplemental funding?
Thank you for that question. Thank you for that question, Congresswoman Underwood. So indeed, we published this report, which, as I noted earlier, documents the progress we have made overall with regards to our national health security and public health preparedness, but that there are areas for improvement. One being this issue with regards to funding for states and localities to be able to really respond in a way that meets these increasing number and frequency of public health threats. We also recognize, too, that this is an important area that not only involves the public health sector. Often we think about these health threats as isolated to public health departments, and yet these are issues that really require a multi-sectoral approach, in one in which we engage various sectors from the business sector to education sector, the healthcare sectors, and others that are really involved and have a seat at the table, as well as the community in driving preparedness and response. So when we think about what the federal government can be doing is really helping to support that capacity for state and local health departments, ensuring that there is that stability of funding so that that type of coordination, that expertise, and that capacity can continue to be built in states and localities. Exactly as, for example, Dr. Dobbs has spoken about, is having the workforce that is trained, having the laboratory capacity, the surveillance that's needed.
Awesome. In your written testimony, Dr. Gracia, you also touched on how the flu vaccination is a proxy measure for our ability to vaccinate a large population once the coronavirus vaccine becomes available. Can you expand on that?
Yes, you know, the flu and what we see, for example, with seasonal flu outbreaks demonstrates a couple of points. One, it shows how public health departments often are having to deal with multiple types of crises at the same time, and so how they can be stretched with regards to really being able to respond to the needs of the public. But secondly, because the flu vaccine, it is a vaccine that is recommended for almost a majority of the population. It's recommended by the CDC for individuals who are 6 months and older. It also demonstrates what our vaccine infrastructure looks like, in particular with regards to if we were in need of doing a mass vaccination campaign, for example, for adults. Children are seeing their physicians and other healthcare providers more frequently. With adults, that may be more difficult. And so in looking at how we're actually doing with seasonal flu, as a nation, the national average for seasonal flu vaccination is 49%, whereas the actual recommendation from the Department of Health and Human Services in the Healthy People 2020 is to reach 7%. Yeah. We recognize that there are shortcomings and gaps with regards to that infrastructure. That entails public health departments, healthcare, commercial entities as well, to ensure that the population is vaccinated.
And speak about why flu vaccination is such an important part of our response to this threat.
So in particular, we are currently in the midst of, the flu season, and we'll have high activity across states. It's important that we know that the best way in particular to prevent the flu is through flu vaccination, and that many of the preventive measures that we also talk about with regards to hygiene and hand washing and staying home when sick, that those are similar of preventive measures and guidance that we're providing as it relates to COVID-19 and the novel coronavirus. And so as we think about what may be needed down the line in regards to the types of interventions, really building the capacity to respond to outbreaks such as the flu is important as we think about outbreaks such as COVID-19. We had the deadliest flu seasons in the 2017 to 2018 flu season in nearly 4 decades. And so that really as to how we as a nation are prepared for these types of outbreaks.
Well, thank you all so much for being here and for your testimony today. I yield back.
Thank you. The chair recognizes the gentleman from Texas, Longhorn State, Mr. Crenshaw.
Thank you, Mr. Chairman. Thank you all for being here on this important topic. This question goes to the gentleman from New Jersey and the gentleman from Mississippi. I just want to get your take on the proper roles at the state level and the federal level. We hear we're unprepared, we hear we're way unprepared, or we hear we're doing pretty well. It's all relative in the end, how well prepared we are. So I want to get an idea from you at the state level. What does preparedness look like at a reasonable standard? And what is the different function of a local county public health center versus the state level versus the federal level? What is the best way to interact?
So first and foremost, preparedness looks like having the funding and resources needed at all levels of government to adequately respond to what we're seeing day to day. And that requires our acute care facilities, our hospitals, our long-term care facilities, our health departments, having whatever they need immediately to conduct their job, continue providing high-quality clinical care to those that are ill, allow the resources and staffing and information needed at the local departments to ensure appropriate case management, contact tracing, and overall management of the pathogen in the communities as needed. Coordination and communication at all levels of government is incredibly important to ensure that the states have a unified, coherent strategy on mobilizing all of the preparedness activities and resources that they have available to them. Without timely information from the top about important policy decisions that are being made.
Can we get an example? And I kind of want to dig into the preparedness, because you basically just said when everything is perfect, that's prepared. But that's not reasonable. As for a reasonable standard, so I mean, how much better can we be reasonably? I mean, I want to have reasonable conversations here. Of course, we could quadruple your funding, and then you'd be more and more prepared, and you'll come back next time and ask for even more money. I know how this goes, and that's all fine. Of course, we want to be getting better, but within a reasonable construct, what does prepared look like? How many masks, how many pieces of equipment are reasonable to ask for, and that we should have had ready prior? What exactly was the federal government not communicating to you effectively?
What has been said moments ago, that continued funding over the past several years to continue to maintain, build upon from previous outbreaks such as Ebola, Zika, the opioid crisis. There's been a lot of work that's been maintained, but the increases and decreases of funding year over year degrades the preparedness activities that we have put into place. And so ensuring that again, that the resources are available to the states.
That's the federal government's job to make sure the states have the resources. So where is the state's role in that, and why can't you be ready to the standard that you've set for yourself?
We are ready to the standard we've set for ourselves. It's a matter of maintaining that level of preparedness year over year, because in between those years, the states are managing disasters, public health, natural disasters, technological, that we use those resources and those preparedness activities to respond to. And so it requires tight coordination, support from the federal government to ensure that, year over year as the states prepare for and respond to various disasters, that capability is rebuilt and, exercised for the next disaster.
Sure. I'm just trying to get more details because I'm trying to get examples on exactly where did we fall short and what exactly was it, and how can we do better the next time? I understand that we always need more coordination and that we can talk in vague terms and say more funding and more coordination and all of that. We're really trying to get into some specifics here. Maybe a gentleman from Mississippi, some insight from Mississippi.
Yeah, thank you for your question. I think one of the things that's important to think about from a state perspective, and I've been doing this for a long time, is that state budgets and county budgets especially are very susceptible to the business cycle. And when they contract, they cut permanently. And so the stability that we see primarily is going to be for better or worse. There's a lot more stability from the federal funding sources. And so that can be the bedrock of public health. The other thing that's happened, I think, almost philosophically, as we've worked to expand insurance coverage to people, which is important, and I think people need health care. But there's been an assumption that public health and health care are the same thing, and they're not at all the same. I have about half the nurses I had 4 years ago. And so how do you respond to a crisis when I can't pull nurses to go to houses and check on people? So I think this sort of communication about health care versus public health has distracted a little bit from some of our needs. And then the other thing, I think relationships is so important. So sometimes some places we have great relationships with the local folks in the counties and stuff. We have those relationships pre-built. It's not just a money thing. It's a slow investment so that when things do go bad, we just call Joe and say, hey, we got this going on and we know what to do together. And again, that gets to the stability and the steadiness of how much better it is just to have a slow and steady approach than having a more reactive approach.
I'm out of time. Thank you, Mr. Chairman.
Thank you. The chair now recognizes the gentleman from Louisiana, Mr. Richmond.
Thank you, Mr. Chairman. I'll pick up where my colleague left off, talking about specific examples, and Mr. Klain, I'll ask you, but not having a test explain to me, was that necessary? Was that incompetence? Was it just oversight? Tell me how it is that Korea has more tests than the United States.
Congressman, I think this is, as I said in my statement, a failure of U.S. policy and execution. The President imposed travel restrictions on people coming here from China. And those travel restrictions, though uneven and not complete, slowed the pace of the disease. It bought us time. Buying time works if you use the time productively. And we knew in December, in early January, we were going to need millions of tests. I've said we should test 30 million people in the United States, seniors who have access to seniors, people in nursing homes, doing surveillance, as several members have said, not just waiting for people to raise their hands and say, test me. And we knew we needed that in January. And the CDC pursued building its own test that turned out to be flawed. It didn't adopt the WHO test. And we don't really know what significance there was in the messages that the president sent, that this wasn't a big deal. He said as recently as 15 days ago, there were only 15 cases and it's almost resolved. So you had a series of management failures, bureaucratic failures, execution failures that leave us so far behind other countries. It isn't a scientific problem. If they can test 150,000 people in South Korea, America can test people too. They don't have any wisdom we don't have here. So that's a failure of execution in this country.
Thank you. Dr. Dobbs, let me ask you, as a lead state health official in Mississippi, I want to engage in a conversation about the collateral consequences and challenges that you face. So let's take Gulfport, Mississippi, and I am a casino worker that gets paid by the hour. Biloxi and Gulfport survive a little bit on tourism.
if I'm feeling down, how do we get that person to take those days off that's necessary or self-quarantine for 14 days and still pay their bills at the end of the month?
Thank you for the question. That's an enormous challenge, and we've been engaging with business communities, especially businesses that have hourly workers. And not that we have a resolution to this at all, but it is a big challenge because people who work hourly and get paid and sick leave are not going to do it. At the state level, state government, you actually have to take a vacation day before you can take a sick day. And so people are not going to want to take their vacation day. So we are looking at any emergency declaration to actually do away with that. So with government, there are, I think, opportunities to address those inequities. But in the business community, it is a real challenge. And I think we, a country and as a state, really need to look at options we can do to make sure people can have paid sick leave. And then the other thing to think about, and there's not an easy answer to this either, is when people have to go home and are out without a job for 2 weeks, who's going to pay the power bill? And we're working with nonprofits, and I know there's some capabilities to do that, but it could be a big issue. It might be a lot of money.
Let me ask you a question, and I'm completely thinking out the box, but in New Orleans, we are accustomed to natural disasters, whether it's hurricanes, whether whether it's, levees. That's where FEMA steps in with either individual assistance or public assistance. And they start off with a certain, and then you have to go improve your need and all of the other things. Is FEMA the agency that we could task with providing either individual assistance, public assistance, if needed? Somebody out there, if we want to be responsible for this, somebody out there is going to have to provide some assistance. So could FEMA do that under the individual assistance program?
Technically speaking, I'm not quite sure the best mechanism, but conceptually, it sounds like a very good fit to me. I mean, if we align this with a disaster response, it seems like it makes a lot of sense.
Ron?
Congressman, if I could, 5 years ago, I wrote a piece where I said that Congress should amend the Stafford Act to add epidemics as a disaster for the purpose of the Stafford Act. Right now, FEMA could do what you suggested if you saw another hurricane in your state or an earthquake or a fire. But epidemics are not a natural disaster under the Stafford Act. And to go back to a question Congressman Crenshaw asked, I think that's a zero cost. I mean, not ultimately zero cost as you draw down on it, but the kind of thing that we should be doing to get prepared. Because whether it's this one or another one, someday we're going to face an epidemic that really is a FEMA triggering disaster, and the Stafford Act should catch up with that.
Thank you. And to the former chairman, when I got here, Mr. King, New York, one of the last recommendations that we still have not adopted from the 9/11 Commission is to put all of the jurisdiction to responding to natural disasters and others and putting the Stafford Act back under Homeland so that we could coordinate. And I think now may be the time for us to raise that issue in a bipartisan manner to get Homeland the jurisdiction that it should have.
Long overdue, and the gentleman raising that issue again. Thank you.
Thank you. I yield back.
Thank you. Let's see. Mr. Newworth and Lee. Oh, I'm sorry. I've done that once before, too. The chair recognizes the gentleman from Texas, Mr. Green.
Thank you, Mr. Chairman. And thank you, ranking member, as well. Thank the witnesses for appearing. There are times when we are not as alert as we should be.
Okay.
And I do confess that as I listened, I was not as alert as I should have been, because I seem to believe that I heard Dr. Dobbs indicate that in Mississippi, you have to take a vacation day before you can take a sick day. I'm confident that I was not as alert as I should be. I should be more alert. I should hear. I should listen. Dr. Dobbs, tell me that I did not hear you properly, that I misunderstood, please.
No, sir, you are absolutely correct. That's just for state government workers, though. That's not for everybody, but I mean,
they eat like the same way everybody else eats. You was telling me that in Mississippi, if you are sick before you can have a day of sick leave, you have to take a day.
Yes, sir.
Do you know of any other state in the United States where this is prevalent?
You know, I didn't know that that wasn't prevalent. I didn't know any better.
So it's, well, maybe I don't know better either. Staff, somebody please help me. I want to know, because that shocks my conscience, to be very honest. It does. Sickness and vacation are totally antithetical. I mean, they're not the same. They're not in the same class of time. Leave. But you've given me reason to pause and think. Now, back to why I'm here today. Much of what we hear and learn when we experience these circumstances is counterintuitive. Wearing some sort of gear on your face, public believes that that's beneficial. People go out and buy as much gear as they can for their faces because they assume that it will protect them. The staff has provided me with some intelligence that I'd like to share with you, and I'd like to find out what your thoughts are. It reads, many countries, actually it's many, but I'll say countries, many countries have implemented travel bans, restrictions, and border closures against China and other affected nations. Notably, the World Health Organization, WHO, opposes the use of travel bans, and public health experts have expressed skepticism of the effectiveness of a travel ban. Now, I'm a layperson. I read this. I see travel bans in place. Would somebody kindly give me your thoughts on what the World Health Organization has indicated in terms of its opposition to the use of travel bans and the skepticism of the effectiveness?
I'll try to start, Congressman. I think the issue is that there's been numerous studies of travel bans through the year, and what they find is that they can delay the introduction of a disease but not stop it. We're living through that right now. The Trump administration imposed a ban on some travel from China, and yet coronavirus is here and spreading rapidly. It did delay, I think, the spread, but it didn't stop it. Now, why? In part because by the time the spread, 200,000 or 300,000 people from China had come here. Now the disease also is coming from Italy. It's coming from all kinds of other countries around the world. We can't stop the spread of that. The travel bans never prevented Americans from traveling back home to our country, as it should not. But Americans can bring disease to our country as much as non-U.S. nationals can. And even the Trump's travel ban with regard to China exempted crews of planes and ships. Now why? Because our healthcare system needs imports from China. We can't have the kind of things these other people are talking about, PPE, drugs in the healthcare system, unless they're coming in our supply chain from China. So boats from China bring those things here. Those boats are driven by men and women who are Chinese. And so that was exempted from the Trump travel restrictions. So my point, we live in an interconnected world. Travel restrictions are always going to be incomplete and imperfect, often too late. That doesn't mean that an effort to slow the disease wasn't smart. I think it was smart in some respects. But obviously, we're living the reality that it did not keep this virus out of this country.
Thank you, Mr. Chairman. I'll yield back.
Thank you, sir. Please ask for unanimous consent for Representative Jackson Lee to sit on the panel and ask questions. Chair will recognize the gentlelady from Texas, Ms. Jackson Lee.
Thank the chair for his courtesies and the ranking member as well, and thank you for holding this enormously important hearing. I'm going to ask unanimous consent to submit into the record a coronavirus plan of action that I introduced about 2 months ago. Ask unanimous consent.
No objection.
Thank you. Let me thank all of the witnesses that are here, and it's my intention to try to ask quick yes or no answers. I may focus, not painfully, Ron, Mr. Klain, on you, not painfully, but because you have the federal experience. And that's where we're now. To the health nonprofits and state agencies, I want to make sure that we're being as helpful to you as we possibly can. So we may have just the straight yes or no answers. What I do want to say is that with the leadership of the House, we passed an $8.3 billion funding that includes, through the emphasis of members on this committee and others, funding to state and local health agencies. We hope that you will see that money for purposes that you need to see them. So my line of questioning will be along those lines, and then I'll spend some time with Ron Klain. So, Mr. Commissioner Newworth, do you have test kits in your possession in the state of New Jersey?
I have 2 test kits in possession in New Jersey.
And is that entire state, or do you think your local agencies have test kits as well?
New Jersey has 2 test kits, each with 500 tests in them. We can test a maximum of 432 individuals with 2 test kits.
So even though they have, you said 500 total?
500 apiece, of which 432 total between the 2.
Okay, even with me adding and saying, oh, you have 1,000, you're saying you can test 432?
Correct. Each individual requires more than 1 test.
And do you mind me saying, and this is only a news report, that your Authority Director, recent news reports is indicating that the port, I guess, of New York, New Jersey is now infected with the coronavirus? Is that something you can affirm?
I too have seen that in the media.
All right. Let me then, Mr. Dobbs is with Mississippi State. Thank you very much. How many test kits do you have, sir?
We have the capacity to run about 700 tests.
Okay, so in that, can you say how many test kits you have? I know that you do several out of that.
We just got a shipment of additional kit, and each kit will run a bunch of tests, obviously. So we have some left from the previous one, and then a new one that we just got in this week.
Okay, so you wouldn't, 700, does that mean on one individual?
That'd be 2 tests for each person, yes. Right. So about 300.
So you're down to 350 persons that you could test. Yes. Okay, and I'm not familiar with Trust for America's Health. Is this
Yes, Congressman, we are a nonprofit, nonpartisan public health advocacy policy organization. One of our priorities is public health emergency preparedness, and we produce an annual report called Ready or Not on the nation's readiness.
Let me just quickly ask you, there's a debate about the contagious nature of coronavirus. Would you say that it has a high level of contagiousness, if you will?
We are seeing that it's a coronavirus that has easy transmissibility, and so the way in which we're talking about taking preventive measures and precautions is similar to what we would do for other types of respiratory.
Does it have a higher level of contagious factors?
So we're still learning a lot about the disease. Okay. I think, one, we recognize enough that, yes, person-to-person transmission, we're seeing community spread in certain parts of the country. Right. And so because of that, are taking these types of precautions.
I think to a higher degree maybe than some others. Or people are not confusing it, but comparing it to the flu. And I don't pretend to be a professional, but I would venture to say that the flu does not equate in its contagious factors to now the coronavirus. So I'm going to go to, I was almost going to call you Ron, Dr. Klain, but let me move forward. My premise is that we have not been effective as a federal government, starting with the administration. Ebola under the administration of President Obama and Biden, and one of the more difficult cases was in hospital in Dallas in the state of Texas, where medical providers, nurses, and others, someone took off for a wedding, someone else took off for vacation. But let me ask this. I think we had knowledge of this in December of 2019. We've been the roadmap. Preventative equipment for our health providers, storing up our test kits so that they could be appropriately distributed, the appropriate documentation to inform people about washing hands and otherwise, coming out with an immediate statement, say right after the first of the year, talking about preparedness and not panic. Can I yield to you on the response that you've seen so far?
Thank you, Congresswoman. I would say there are 3 things that should have happened in January that didn't happen. First, a real focus on getting this test capacity problem solved, either by adopting the WHO testing approach or by some other solution. We're just way behind, and as a result of being behind, we can't really have an effective containment strategy of identifying where the disease is. It's in a lot of places in this country. We don't know where it is. That's a problem. That's a failure in testing. Secondly, I think getting our medical facilities preparedness for a surge of cases, particular hospitals, particular communities, community health centers are going to see an influx of cases and not really have the capacity to deal with that. I think it's really a problem. And the third is, I think, crisper communications about warning people that this was coming. I understand we don't want to panic people. We don't want to be hyperbolic about it.
Okay, thank you. Finalement, alors qu'est-ce qui se passe avec notre satellite? Ça marche toujours pas, cette affaire-là? Je le dis, là, tu sais, la soucoupe en papier fonctionne jamais bien que notre soucoupe en styrofoam. Là. Quand on regarde la couverture. Allô Anaïs, on a failli l'avoir sa gueule encore une fois.